Venous thromboembolism, or VTE, commonly presents as deep venous thromboembolism, or DVT, of the lower extremities, or as a pulmonary embolism, PE. Physicians frequently diagnose and treat VTE with anticoagulation in a timely manner to significantly reduce a patient's morbidity and mortality. It is important to recognize these risk factors for VTE, both inherited and acquired, to treat these patients in a timely fashion. Many patients who experience a VTE have multiple acquired risk factors for thromboembolic events. The patient we are discussing is a 49-year-old female with no known risk factors who developed a PE days after undergoing a diagnostic colonoscopy. This is a 49-year-old female who presents to the emergency department with 2 days of left-sided pleuritic chest pain. She had no dyspnea or lower extremity swelling with pain. She only had past medical history for hypothyroidism and constipation, predominant irritable bowel syndrome. She was seen by her gastroenterologist several days prior for constipation and rectal bleeding. Colonoscopy was performed with findings of the internal hemorrhoids and 2 sessile polyps removed by cold snare. Scope withdrawal time was 12 minutes and total procedure time of 19 minutes. Patient returned to her normal routine after the colonoscopy, however, developed chest pain several days later, prompting an ED visit. CTA of the chest revealed right lower lobe pulmonary embolism. A bilateral lower extremity ultrasound was negative for DVT. Further workup for PE included a negative hypercoagulable workup and she was not on any hormonal therapies. Her BMI is 28. She is a non-smoker. The patient was hospitalized for 1 night and discharged home with improvement of symptoms after being started on anticoagulation. Colonoscopies are generally a low-risk procedure. It is uncommon for development of PE shortly after colonoscopy, as in the patient that we are talking about. She had no risk factors acquired or inherited, and her workup was negative for inherited risk factors including factor V Leiden and prothrombin gene mutation, protein CNS, and antithrombin deficiency. With both negative inherited and acquired risk factors, we question the possible causes of her pulmonary embolism. An explanation could include lying in the same position during the procedure with the combination of intravenous sedatives. However, a retrospective study identified a post-operative VTE were most commonly seen in surgeries that were 3.5 hours or greater. Another explanation could be considered is increased abdominal pressure from insufflation, causing a decrease in femoral venous blood outflow, further leading to DVT or PE as seen in animal studies. The mechanism of thrombus formation in the patient remains unclear. However, her recent colonoscopy cannot be ruled out as a risk factor. In conclusion, colonoscopy should be considered a possible cause in patients who developed an idiopathic pulmonary embolism.